let's move to our speakers, and just to introduce Des O'Neill. It's my pleasure to introduce him. He's a leading figure in geriatric medicine and aging research. He's a consultant geriatrician and professor of medical gerontology at the Trinity College Dublin. Over the course of his career, he's been an advocate for the rights, dignity, and quality care of older people, both in Ireland and internationally. And his clinical work spans acute hospital care, rehabilitation, and age-related health policy, and he's contributed extensively to national and international working groups on this issue. In addition to his expertise, he's a respected researcher and commentator on age and dementia, medical humanities, and the social perception of later life. So Professor O'Neill, thanks for joining us, and over to you.
Thanks very much. Thank you very much indeed. And I think it's good to have any debate like this. And indeed, it's important it's not an echo chamber. And I understand that we have a broad spectrum of opinions across the participants tonight, and that's very much to be welcomed. This is, just to say in the background as well, I both teach in ethics at undergraduate, postgraduate and CPD level, and also I have a considerable amount of peer-reviewed publications in ethics. And I think this is an ethical issue of very major proportion. It's one that makes us think and reflect and question what it is to be human, what it is to be vulnerable, where caring fits into our paradigm of both ourselves and as part of our moral development for others, and to try and ensure that certainly within the medical profession is that we generate a sense of the importance of moral reasoning and ethical debate. This is a hugely concerning area, and I think it's particularly concerning for people living with disability. And indeed, as the disability sector would say, we are not the able-bodied, those of us who so think they are, we are the presently able-bodied. And disability and vulnerability is part of our makeup. Indeed, it's very often our vulnerabilities which allow us to truly understand who we are and what is our meaning. And into this arena, we're now beginning to see hugely worrying trends against disability, in some ways a form of a personalized eugenics, in that there's only one way which we should live, in terms of, Thomas More would have had a field day in his utopia in this area here. Now, I'm not a Pollyanna about suffering and the challenges of meeting with suffering, but there is a real danger when we see, major figures with important following in the UK, like Joanna Lumley, saying that if she can no longer speak or feed herself, she no longer wants to live. And I think of all the people I have in our clinics, whether it's having aphasia after a stroke, or those whose verbal output is limited in many of the dementias, but whose internal lives are rich and relationships. It's really worrying that this type of debate is tolerated, or this type of utterance is tolerated. Joanna Trollope did something similar, using horrible language about life with dementia, if I go gaga. So we've got to be mindful that there is still a huge scope out there for prejudice against disability. And it's no accident that Hope Ireland, a secular grouping in a pluralist society, was founded by a person living with disability, Dr. Kevin Fitzpatrick. So just coming back to the issue of ethics, I think one of the real challenges here is there's the whole question puts an enormous stimulus to us in medicine to up our game in terms of ethics teaching and ethics articulacy. We have a particular problem in Ireland in that, with the overdominance of the Catholic Church up until recently, ethics teaching virtually, I think possibly as a counter-reaction, an understandable counter-reaction to this, was nugatory or not present. I came through Trinity College Dublin in the late 70s, early 80s, and we didn't have 1 second of ethics teaching. I came across some very good ethics practice, But the real problem, I think, for our generation, and we need to see for subsequent generations, is whether they have the ethics toolkit, the ethics articulacy to be able to engage with subtle, complex, and challenging concepts like these, and to be able to articulate a response. And certainly, I would think that we really do have an issue here. I've been looking at and hoping to collect more widely, for example, the questionnaires that medical professional bodies have put out to their constituent members. And very often they're extraordinarily simplistic. Are you in favor of legislation for assisted suicide, euthanasia, or as the advocates call it, assisted dying? Rather than perhaps more searching questions such as, do you feel you have the appropriate continuous professional development in ethics to allow you to reason and debate with this? Do you think that assisted suicide and euthanasia conforms with a caring outward approach towards people living with dementia, people living with deep forgetfulness and similar types of limitations? And perhaps the most important question of all is, do you understand the pattern of expansion of euthanasia in virtually every country, jurisdiction, or state in which it has been introduced? And I think this is the key element. Again, I will come back to this is a question that needs to be based on intellectual, moral grounds as well. But the last question, that of what actually happens in jurisdictions where assisted suicide and euthanasia are permitted, should cause at least a halt and a question for reflection. And indeed, as you're possibly aware, and I think it's the issue here in Ireland, the ethics legislation, the legislation for assisted suicide and euthanasia was been very much promoted on the fact that it would be exceptionally limited and also that it would be well regulated. Well, as it turns out, and I think even those who are potentially advocates in this area here would know that to say that assisted suicide or euthanasia can be limited or regulated is both intellectually dishonest if you have embedded yourself in this field, and it's professionally inappropriate. For Oregon, for example, what's been really worrying when you look at the 25-year review is that increasingly, for example, people are quoting financial hardship, again, in a healthcare system where access to health is on the basis of finances, and a sense of feeling a burden. And again, what kind of a relational society have we made where we let people who've got illness or disability feel that they're a burden? But in nearly every jurisdiction, in fact, in every jurisdiction, most recently, Oregon is often painted as the poster child of where the limits have not been opened out, but they have been opened out recently with the proviso that if you threaten that you will forego food and drink, then you now fit into the 6-month life expectancy. There's also fantasy football around the idea that any of us as a doctor can predict when somebody has only got 6 months to live. 6 weeks, possibly. 3 weeks, possibly. 6 months, not a chance. I've been a geriatrician for 40 years. The idea that you can say when a person has 6 months or 12 months to live is an act of folly or hubris. I've seen patients when I passed through medicine in the early days, ovarian cancer or a glioblastoma multiforme did tend to be 6 or 9 months. Now we're seeing people living for considerably longer periods of time. We have a healthier baseline population, different presentations, earlier detection, better healthcare systems. So trying to decide when that people can fit into this It really is important for us as healthcare professionals to respond back to the legislators and to educate the public to say, this is not on. We cannot do that. So it's not a question of saying no. It's a question of reframing our view of what our social contract with medicine is, so that it encapsulates support for those of us who are living with disabilities, and for those of us, the able-bodied, who know into the future that we can have confidence. So in terms of ethics, and I'm going to finish off here now because I know we're getting near to 7:45 and give time for Eric and Tani and debate. What's very helpful is to turn to professional ethicists, people who do this both clinical and theoretical. And when we're looking for guidance in life, we often look to the Nordic countries. They seem to have a caring, mutually supportive framework. So the Danish Biomedical Council on Ethics recently submitted a major report which said that this is a deeply imprudent idea that should not be entertained further, because it radically alters how we view each other, how we view care, and how we view aging. So we'll get more in as we go along, but really I would implore people to go looking. If we're all autodidacts to a certain extent, Medline, PubMed, which is the wonderful online database, is packed full of medical ethics. You'll get it from all sides. You'll help pick up the terminology. But I think it's really important that we help the public, our colleagues, our patients, understand the nuances, the challenges, and the dangers here. We also need to prepare for how we might work if the system does come in. You may or may not know that if a person has a very severe dementia, it seems obvious they need nursing home care, but they say, no, I want to go home. To deprive their liberty, we've got to go to the High Court. And I think if deprivation of liberty to go to a nursing home requires the High Court, then certainly this graver, deeper thing requires a deeper embedding in a decision process. We can also ask ourselves whether it has to be doctors who would do this, or whether this actually distorts our very raison d'etre and rationale for caring and minding and reminding ourselves that we too are human. So thank you very much. It's a great opportunity. I look forward to the questions in the panel.
Thank you very much, Professor. And just for anybody who has a question, if you put in the